So thank you for joining us in our international rounds. And it's my great pleasure to introduce Dr. Egbe, who is a staff cardiologist at the Mayo Clinic. I'm going to talk today about Ebstein anomaly, but not just about the tricuspid regurgitation. So what other things we need to look at in patients with Ebstein anomaly. Thank you, Alexander, for joining us, and the floor is yours.
Okay. Thank you very much for having me, and I'll be talking to you today about Ebstein anomaly beyond the tricuspid valve. I have no disclosures. So I'm going to start with a case presentation. And this is a case of a 24-year-old male that I recently saw in the outpatient clinic. He was referred to Mayo Clinic for the first time for surgical consideration because of severe TR and severe RV dysfunction from Ebstein anomaly. He denied any cardiovascular symptoms and actually described himself as being very physically active and doesn't feel limited in any way. He's not on any cardiac medication and has never had any arrhythmias. So we obtained an echocardiogram. So on the left side of the screen here, you see the parasternal short axis view, just around the level of the AV valve. So this little thing here is the left ventricle and short axis, and all this is the right heart. So this is the tricuspid valve. In the middle panel here, you see the apical four-chamber view with the apex down. So this is the classic Ebstein anomaly with a large anterior cell-like leaflet that is tethered. You can see the apical displacement and tethering of the septal leaflets, and on the filling of the left ventricle. And on the right is a steel frame in mid to late systole showing you torrential TR. The blue is the jet going away from the probe. So the echo was read as severe TR with severe RV enlargement, and the RV global longitudinal strain, we're going to call it GLS for the rest of this talk. So RV GLS was -11. The LV size was small, as you can see. The EF was 56%, and the GLS was -15. So this is important. So small cavity LV, normal LV EF, reduced strain. Although he described himself as being very physically active, his peak VO2 was only 49% of predicted. And just for reference, we want it to be at least 80% of predicted. So we got a comprehensive metabolic panel, and using the indices from this test, we calculated the MEL score, and it was 12.6. And again, remember this, we're going to come back to this case at the end of the presentation. So this will be the outline of my talk. I'm going to give you a 2-minute overview of Ebstein anomaly the way you know it, which is just disease of the tricuspid valve. After that, we'll move quickly to the focus of the talk, which is to discuss the other problems that are associated with Ebstein anomaly. We'll talk about LV dysfunction, atrial dysfunction, and hepatorenal dysfunction. Then we'll close the talk by integrating these new findings and discuss the emerging paradigm of care in this population. So let's talk about Ebstein anomaly the way we know it. So as you all are aware, it's all apical displacement of the septal leaflet that is also tethered, as well as tethering of the anterior leaflet. And this results in a small dysfunctional RV, atrialized RV, and a huge functional right atrium. And this pathology is what drives the pathophysiology, which is TR, RV dysfunction, RA enlargement, and dysfunction. As a result, the treatment is targeted at the pathophysiology, which will be address the TR by repairing the tricuspid valve. And when you cannot repair, then you should replace it. Then try to improve the hemodynamic function of the right heart by reducing the size of the RV and the RA. So that is overview of Ebstein anomaly. So let's move on now to LV dysfunction in this population. So we're going to address two questions. What is the ideal method for assessment of LV systolic function in people with Ebstein anomaly? And what is the prevalence and prognostic implication of LV systolic dysfunction in this population? So as we all know, LVEF is the holy grail of cardiology, is the most widely used and most widely understood metric of LV systolic function. And it works out pretty well as long as you meet the assumptions that go into it. There is a geometric assumption that the LV has to be bullet-shaped or like a prolapse ellipsoid. And again, we assume that the loading conditions, that's the preload and afterload, are within physiologic range. If these assumptions are met, then LVEF is a good reflection of LV systolic function. But unfortunately, these conditions are not met in Ebstein. So this is the patient I just presented to you again. So the LV geometry is abnormal. So in short axis, you expect to see this as a circle, but this is almost D-shaped. And again, from the apical view, you see the septum bowing into the left side. So the geometry is abnormal. And again, the loading conditions are abnormal. There is reduced preload in these patients. And it's due to a combination of problems, the TR, RV dysfunction, and pericardial restraint. So if these assumptions are not met, how accurate is LVEF as a measure of LV systolic function? So we have two options. We can use the EF or we can use the GLS. But whatever we choose to use, the ideal metric should correlate with heart failure hemodynamics, that's your cardiac index and systemic venous congestion, end organ function, and it should track with changes in the patient's clinical condition. And of course, it should be able to predict mortality with it and help you change your management plan. But we don't have this data, hence the knowledge gap. So we're trying to determine, is LVGLS superior to EF in this population? So what we did was that we studied 673 patients, and the average LVEF was 59%. And if you apply the ASC criteria for LV dysfunction, 11% will have LV dysfunction. That's the prevalence here. The LVGLS was -21, and using the cutoff point of -18, if you use that, the prevalence of LV dysfunction more than doubles. So what we did was that we divided these patients into 4 groups by using LVEF normal versus abnormal, LVGLS normal versus abnormal. So if you use this thing, you get 4 different permutations. So normal, low LVGLS and normal EF, like the patient I just presented, low GLS and low EF, and normal GLS and low EF. So there are only 6 patients in this group, so it's too small for analysis, so we excluded them. And just to make things simple, we call the people that had both indices as being normal, as normal LVEF. If your GLS is low and your EF is preserved, we call it occult LV dysfunction, such as the patient that I presented that had EF of 54% and GLS of -15. And if both of them are decreased, we call that overt LV dysfunction. So what we did was that we compared the hemodynamics between the 3 groups. So the normal group had near normal cardiac index, NT-proBNP as a measure of volume status and venous congestion was a bit elevated, GFR was normal. And if you look at the overt group, so cardiac index is lower, more evidence of volume overload, more renal dysfunction. So that's not surprising. What is interesting is that the occult group, these people have normal LVEF. The cardiac index, the NT-proBNP and GFR are all reduced relative to the normal group and almost identical to what you find in the overt LV dysfunction group. Another important observation was that the prevalence of symptoms as reported by the patient is about the same. So symptoms are very unreliable, as I'm going to show you throughout this talk, and it doesn't track with hemodynamics at all. So what we showed here was that the LV-GLS had a stronger correlation with heart failure hemodynamics and organ function, as shown by the correlation coefficient. So the higher the number, the stronger the correlation. And of course, none of them correlated with patient-reported symptoms. So going back to the patients, so in the course of follow-up, 317 underwent tricuspid valve surgery, while 261 had no surgery but had multiple echoes during follow-up. So for now, let's ignore the people that had surgery. So for these other patients, we assessed the echo and clinical status at baseline. We'll call that T1. And again, minimum of 2 years apart, we'll reassess them with, there's no intervention between T1 and T2. And our goal is to see what happens. Do the LV systolic function indices decrease over time, and does it track with changes in clinical status? So what we found out was that among these 261 patients, there was a temporal decline in LV-GLS. And with that, there was a decrease in cardiac index, renal function, and increase in venous congestion. Interestingly, the EF didn't change. And again, the patient-reported symptom didn't change. So just showing you that using EF will make you miss deterioration in clinical status. And more importantly, the patient groups had different outcomes. So those people that had normal function had the best outcomes, which is not surprising. But what is interesting here is that the so-called occult LV dysfunction group in black, this will have normal EF, they had suboptimal outcomes and is almost identical to the overt group. So let's go back to our flow chart. So let's focus on the people now that had surgery. Again, we measured their, had a clinical and echo assessment at T1, which is the last assessment before tricuspid valve surgery. Then minimum of a year post surgery, we had another assessment. And what we did was at baseline, as this is pre-op, we wanted to see how different were their left heart volumes. So focus on the normal group for now. So this is end-diastolic volume, normal, but on the low side, and systolic volume, normal stroke volume, normal EF. If you look at the overt group, the LV was bigger, stroke volume was lower, EF was lower. The occult group is very interesting again. Their end-diastolic and end-systolic volume is smaller. So if you recall the case I showed you, you see that the septum is bowing to the left side, so there is underfilling of the LV. And the stroke volume is actually worse than what you find in the overt group. And of course, the EF is preserved. The EF is preserved because the denominator, which is end-diastolic volume, is low. So this is erroneously increased. So post-op, we looked at the LV adaptation, and it was different across the three groups. So the people with normal LV function had improvement in LV volumes due to just improved preload to the left heart. Stroke volume increased. The EF remained the same, GLS remained the same. The people with overt LV dysfunction, nothing changed. So this is too late. The people with occult LV dysfunction, again, had an interesting response. So the end-diastolic and systolic volume increased because the right heart is able to pump more blood to the left heart, but the stroke volume didn't change. And the EF actually went down. So what's happening here now is that you're now feeling the LV more, so which is this is the denominator, and that kind of brings down the EF. So the EF really didn't drop. It's just that you're kind of unmasking and unmasking LV dysfunction that wasn't apparent before. Sorry, and of course the LV-GLS didn't change. And again, survival was different across the three groups, with the occult group behaving similar to the overt group with regards to survival. So to put everything together about LV systolic function, we've shown by the data that I just presented that LV-GLS was superior to EF for risk stratification because it tracks better with heart failure hemodynamics, cardiac index, and volume status, organ function, as well as changes in patients' clinical status. So let's go back to our outline. So we've talked about LV dysfunction. So now let's move to biatrial dysfunction and how this affects aerobic capacity. So we want to address two questions again. First is aerobic capacity as measured by peak VO2 useful for prognostication in this patient? And if so, what are the determinants of peak VO2? And hopefully, if we can modify those determinants, we should improve aerobic capacity. So to address this question, we studied 248 patients. So the peak VO2 was just 64% of predicted. And that's at the baseline. So we'll always call the baseline T1. And we followed this patient over a median period of 8 years. And during that time, there were some deaths, 1 transplant, 7 aborted sudden cardiac death, and a number of heart failure hospitalization. So what we showed was having predicted peak VO2 less than 55% was associated with reduced event-free survival. This is cardiovascular adverse events. So composites of all this. And this relationship between peak VO2 and survival remains significant even after multivariate adjustment for confounders. If you recall, the patient I presented to you had a peak VO2 of 49%, and again, described himself as being asymptomatic. So we've shown here that peak VO2 is predictive. So next question now is, what are the factors in the heart that determine peak VO2? So we just ran a correlation analysis with all left and right heart indices, and the ones that remain significant were atrial function, right atrial pressure, and left heart indices, LV centricity index, and LV volumes. And again, this is helpful but not very helpful because we don't know what leads to the other. Because for us to discuss mechanism, we should be able to talk about the dysfunction that starts first, the initial insult, and how that leads to deterioration. So you cannot do that with a cross-sectional analysis. You need longitudinal data. So to do this, we had echo and exercise tests at 3 time points, minimum of 2 years apart. But before I discuss our results, I just want to talk about LV eccentricity index, because we don't use this a lot in congenital heart disease. So let's make sure that we are all on the same page. So LV eccentricity index is a measure of ventricular interdependence. So you assess this from the parasternal short axis view, preferably at the level of the papillary muscles. So the D2, you cannot just measure where you have the papillary muscles, posteromedial and anterolateral. And the D1 is from the septum to the posterior wall. So in a normal LV, they should be equal because this should be a circle, so it should be equal to 1. In somebody with RV volume overload, so you're doing this in diastole. So here with RV volume overload, what you see now is that the D2, which is the numerator, is higher than the D1, so it's going to be greater than 1. So the higher the number, the worse the ventricular interdependence and LV underfilling. And again, this is important in our patient again, where you see that here that this dimension is going to be smaller, and this again looking at the septum going to the left side. So what we observe from measuring those indices at 3 different time points is that we noted that the initial insult starts from the right atrium. So there is drop in RA strain, increase in RA pressure, which then leads to worsening ventricular interdependence because of pericardial restraint. So higher LV eccentricity index. So with more ventricular interdependence, you need higher pressure to fill the left ventricle. And this leads to left atrial remodeling and dysfunction, hence a biatrial dysfunction. There is reduced LV volume, which leads to lower stroke volume and lower peak VO2. So that's the trend that we observe over time in our patients. But an important thing that we need to determine now is this a unidirectional trajectory? That means once you start developing RA dysfunction, your life is downhill from there. Or is it bidirectional? Can we do something to reverse this? So to determine that, we wanted to address a question that, does tricuspid valve surgery improve your aerobic capacity? So what we did was that we looked at 76 patients that had exercise tests before and after tricuspid valve surgery. And I used tricuspid valve surgery that because some of them had replacement, but majority had repair. So what we did was that we looked at the difference in VO2 between pre and post, and those we define improvement in aerobic capacity as any increase in peak VO2, predicted peak VO2. And although most of them reported subjective improvement in symptoms, only 27% had any measurable improvement in predicted peak VO2, and the bulk of them didn't change. It actually went down. So we wanted to find out what was different between these patients. So these are the pre-op indices. So the people that improved had better peak VO2 to start with, had better right atrial function and hemodynamics, as well as less interdependence and better LV volumes as compared to those that didn't improve. And post-operatively, they remodeled differently this is the delta. They had more improvement in RA function and hemodynamics and improvement in LV as compared to those that didn't improve. So if we go back to the conceptual framework that I presented, so what we observe now is that for people with significant TR and surgical indication, so if you do the surgery early enough before there is significant deterioration in RA function and hemodynamics, that you're actually able to reverse the decline as improve right atrial function, improve the interdependence, and improve filling of the left ventricle, and hence peak VO2 post-suppuratively. So to put this together, we show that yes, peak VO2 is prognostic in this population, and it is determined by a number of factors, but the initial insult now leads to ventricular underfilling and reduced cardiac output. So back to our outline. So we've talked about LV dysfunction, talked about atrial dysfunction. So let's move on now to the last one, which is hepatorenal dysfunction. So again, we're going to address two questions. I'm sure you're noticing a pattern here now. So first is hepatorenal function as measured by the MELD XI score useful for prognostication? And two, what are the determinants of hepatorenal function? So the MELD XI score stands for Model for End-Stage Liver Disease Excluding INR. And you can calculate this using an online calculator. And all you need is a comprehensive metabolic panel. You just need a total bilirubin and a creatinine to do the calculation. So what we did was that we performed comprehensive metabolic panel in our patients at 2 time points. Again, T1, T2, minimum of 2 years. So, and the average MELD XI score was 9.8. So we divided them into 2 groups as low score of 11 or less, high, greater than 11. And the number 11 is consistent with what's been described in the literature in Fontaine's as being prognostic. And again, using AUC analysis in our study, it was still at 11. If you recall, the patient that I presented had a MELD XI score of 12.6. So it's already in this group. So what we wanted to know is that by the time we reassess them during follow-up, do patients maintain the MELD category that they are in? So do they move from one category to the other? So what we showed was that the people that had high score remained in that high score. It doesn't get better, which again which kind of gives you confidence when you measure it. That means that there's not much noise in it. If it's abnormal, it's abnormal. And the people with normal MELD XI score, most of them stayed normal, but a number of them moved up to the higher group. Again, telling you that things are getting worse from hemodynamic standpoint, and that is affecting hepatorenal function. And more importantly, the 3 groups had different outcomes. So the worst in those that had hepatorenal dysfunction at baseline, followed by those that had deterioration in hepatorenal function during follow-up, and those with normal. So this is when you're looking at temporal change in hepatorenal function without any intervention from the physician. So, and the determinants of MELD score again is right atrial functional hemodynamics and LV stroke volume. And this makes sense from physiologic standpoint because increased right atrial pressure leads to high central venous pressure and congestion of the liver. Low stroke volume and cardiac output reduce perfusion of the kidneys and the liver. So now let's look at what happens when we as physicians intervene, or the surgeon intervene in the patients. So we looked at a different subset of patients, 334, and we measured their MELD XI score at baseline, which is the last test before surgery, and post-op, minimum of 1 year post-op. So at baseline, what we found, again, we divided them into low and high, similar to what I showed you initially. So what we found out was that the people that had low score when they went in for surgery remained in the low score category, which makes sense again because surgery didn't make them worse. It actually improved their hemodynamics, so they remained good. The people that were high, about half of them remained in the high group, so surgery didn't help. And in some, there was improvement, which again makes sense from a physiologic standpoint because the surgery will improve hemodynamics, and if the hepatorenal function is not too far gone, you will have some improvement. And again, there was difference in outcome, worse in the red group and best in those people that had normal MELD score. And again, we identified the same determinants of MELD exercise score in this group, which increases our confidence in these indices. So the take-home point here is that hepatorenal dysfunction by itself is an independent risk factor for mortality in this population. And the hemodynamic derangement that drives this is right atrial dysfunction and hypertension, as well as low cardiac output. So let's put everything together now since we've covered a lot of ground. So first we talked about LV systolic dysfunction, and we showed that using LV-GLS is better than using LV-EF because it tracks better with the clinical condition of the patient and changes in clinical condition and end organ function. And this is important clinically because using LV-GLS will allow you to detect the occult LV dysfunction group, right? Which I showed you, they have normal LVEF and they had very bad outcomes. And if you identify them, perhaps you can intensify heart failure therapy to see if they will get better. So there's a lot of data from the acquired heart disease, that's a general cardiology population, that guideline-directed medical therapy, just beta blockers, ACE inhibitors are effective for LV dysfunction, right? We don't have any trials in this population, but this is a knowledge gap where I think research should focus on to see if we're able to optimize medical therapy, can we improve LV dysfunction and then improve survival? So the next, we talked about biatrial dysfunction and how it affects aerobic capacity. And I showed you that it starts with airway dysfunction, pericardial restraint, ventricular interdependence, underfilling of the left heart, low output, and impaired aerobic capacity. And again, I showed you again that performing surgery before there's significant airway dysfunction leads to postoperative improvement in peak VO2. Makes you wonder whether we should integrate this metric in timing of surgery. But we still have a number of knowledge gaps. And the important one is that not all patients have surgical indication. It's only a small percentage of them that will have significant TR that will require surgery. So in the bulk of the patient who wouldn't undergo surgery, would medical therapy help? The use of diuretics to decongest the heart, would that slow the rate of LV, right atrial remodeling in this population? Lastly, we talked about hepatorenal function. And again, the cause of this is problem with the right atrium and low output. And this leads to increased mortality. You can apply this clinically because just using the MELD exercise score helps you identify a patient who's moving towards end-stage heart failure. And again, these people don't complain of symptoms a lot, usually because they are young. If you recall, our patient had MELD exercise score of 12.6, which is in the high range, but still felt well. So you can identify these patients, since we know that they have bad outcomes during follow-up, and probably move them towards surgery if they have surgical indication, or give them appropriate heart failure therapy, diuretics, ACE inhibitors, and if not, send them for transplant evaluation. And typically, when we heart transplant in Ebstein's, we only think about the heart, right? So now that we know that they have hepatorenal dysfunction, should we start thinking about the liver just the way we think about the Fontanes? And again, there is always things that we need to determine, and that is whether in people that we cannot do surgery for or send for transplant, is any medications that can improve hemodynamics and hepatorenal function. And again, for the people that have gone for isolated heart transplant, we need to follow them to see whether their liver function improves, because that will help inform how to manage these patients. So let's go back to our case presentation. If you remember, the 24-year-old man, so severe TR and has no symptoms. It's not on any medication. And we show that this patient had severe TR, RV enlargement and dysfunction. And again, he has the classic occult LV dysfunction phenotype. So small underfilled left ventricle, which erroneously makes the EF appear normal when the strain is low. He's asymptomatic according to him, but his peak VO2 is just 49%, which is in the low range, and we know the prognostic implication of low peak VO2. And again, his MEL XI score is increased, so there is already hepatorenal dysfunction. And I'm sure you're wondering what happened to the patient. I wish I could tell you that we operated on him and he got better and things changed. I recommended surgery, but he declined surgery. And he said that he feels well, so that he's going to return to us when he develops symptoms. So this is an encounter I had about 3 months ago, so time will tell what happens. And this is my last slide. I just want to thank you for listening, and I hope that if you can take away one thing, and that is that Ebstein anomaly is not just tricuspid regurgitation. There is more to it. Thank you for listening.
Thank you very much, Alexander, for an excellent and very, very interesting presentation, and bringing up really new challenges in the Ebstein anomaly. So if there is any questions, you can either unmute your microphones or write it in the chat. So there is a question on the chat that came while you were talking, and congratulate you for the talk. And they said in the patients that you repaired the tricuspid valve, and how many of them had at least moderate TR, and was the severity of the residual TR related to the lack of improvement of the LV function?
Okay, thank you for that excellent question. So all the patients that went for surgery, almost all of them had severe TR. And again, is that by the time they come to us, they already have severe TR. Nobody had moderate, just severe or moderate to severe. So what we found out was that the residual TR, which is what we call an excellent repair, is having mild to moderate or less. So and that was achieved in more than 93% of the repairs. So the residual TR, or the type of surgery, repair or replacement, it didn't affect the outcome. So that's the thing. So what the tricuspid valve doesn't mean a whole lot. It's a upstream and downstream effect of TR that is a problem. So
there's another question here. So is that was there any MRI data and if there was any correlation between the MRI and your echo data in terms of LV and RV function? I guess that's the question.
Okay. Thank you again for the question. And we have some MRI data, but that's a kind of, I don't know what is a problem with our clinical practice, that we are echo heavy, which means everybody gets an echo. Only MRI is available in less than 25% of the patients. So yeah, so the data on LV function as published in JACC. So we actually showed a table of the MRI data, but it was just in a small population of the patient that you can't really draw much inference. But yes, there is a correlation with the echo-derived indices and the MRI-derived indices.
So there's another question here, as amongst the parameters you discussed between the LVGLS and the MEL score, what do you think is the most helpful in the decision for surgery?
So if we can just put everything together here, is that we are kind of moving towards earlier surgery in these patients. So if somebody comes in now with severe TR and symptoms, that's no brainer. You're going to send them for surgery. Everything I presented here now is to help move you towards dealing with a so-called asymptomatic patient. So like the case I presented now, who says it feels well, knowing that having a high MEL score and having low GLS, we know what's going to happen just by the data. We are moving towards just saying you should go for surgery if you have significant TR.
So I have a question. So in terms of your RA function parameters, which I think I find of the all parameters that you have presented, the ones that are more challenging to reproduce. But have you found any correlation between the degree of tricuspid regurgitation and your RA function parameters? Or is just the RA something that changes regardless of your TR?
So that's a great question again. So before I answer it, I just want to make you understand the limitation of our data. So being a referral center, by the time they come to us, they almost all have severe TR for a long time, right? So we can't really say how much the severity, because they're all in the nearly severe range. But it's over time, there's the net effect of that volume and pressure in the right atrium that drive the remodeling. And by the time they come to us, the RV function is already done. That's why it wasn't helpful, because almost everybody had a bad RV and severe TR.
It makes sense. So there's another question here, and is there has been any difference? So of course you have the biggest numbers in the world in a single center with Ebstein. So, but I guess during these years that you have looked at this population, you changed the strategy and the technique of the repair of the valve. So have you found any differences in these parameters in the patients that were repaired earlier or repaired later with the COM procedures, or any changes with the type of surgery?
Okay, yeah. So the practice has evolved over time. So it's a little over 20 years back, they weren't doing a lot of the COM procedure. They were doing what they call the Danielson repair, the monocuspid repair. But now there is overwhelming evidence that the cone repair is superior. So everybody gets that. And there's overwhelming evidence that tricuspid valve repair, no matter the technique, has more durability than replacement. So it's done by a single surgeon. So the aim is to repair almost everybody. Even when they come back for a second repair, he attempts a second repair. So the people that will now replace are people that have such a bad RV, or there's concomitant LV dysfunction. So the surgeon is trying to reduce the bypass time because the repair takes much longer. So in those patients, he will just go ahead and replace them. And again, with the replacement, we favor bar prosthetic valve, because when you put in a mechanical valve, there's a lot of valve thrombosis just because of the low flow in the right heart.
So I have another technical question. So how long does it take to do the right atrial strain? In terms, how much that add to your echo? And how many of these studies were done offline? So I guess that many of these analyses were done on the post-processing, the imaging, and how many of them you do it in, when you just do the echo when the patient comes?
Okay, so things kind of changed in the last 3 to 5 years now, that we are doing the strain in most of the patient at the time of the echo. But the data that I presented in this study, so for our research work now, we kind of have a core lab where a single observer does all this for the research. But clinically, it doesn't take much longer. So as far as you acquire, so how we practice is that the sonographer acquires the images, and by the time they are doing the report, they just do it offline, but it will be part of the report before the patient leaves the lab.
Okay.
So that means it doesn't take much longer, because the report is so the report is signed by the time the patient leaves the lab.
Okay. So Erwin, do you have I guess that you have a question.
Thank you very much, Alexander, for opening the box about the black box about patient's Ebstein anomaly, because as I said, it's not just a tricuspid valve disease, it's a disease of the entire heart, the right and the left ventricle, including the conduction system, electrical system. I have actually 2 questions. So I understand you do routinely measure the strain of the right ventricle and the left ventricle in patients' Ebstein anomaly in your lab. That's routine. That's part of your routine protocol.
Routine is probably a strong word. We do it we want it done in all the patients, but it's not really being done in all the patients. So it depends on who the person is in the lab, but the majority of people are now asking for this data, not just for Ebstein, as using strain as the 4-chamber strain as part of routine echocardiogram for every patient.
So you do it for every patient, or only if
we do it for most of the, not all yet. We hope at some point we'll be able to do it in everybody that has adequate images for it. So it's an evolving practice.
Now this was my next question, because I also have concerns about the reproducibility of the measurements. So you need to rely on the measurements and rely on the numbers you you receive from the lab. If the reproducibility is a concern, then you cannot use this number to make clinical decisions.
Yeah, so that's something that we'll be able to review sometime in the future. So the problem with real world and research is that research is so rigorous and controlled. So for the research that we have, 2 research sonographers that have done this in more than 600 patients. So they've gotten good at it. So, and we've published the reproducibility of it is pretty good. It's pretty good. So what we don't know, I don't think it will be the ones that are done clinically will be that tightly correlated, but we've not really looked at it yet. So that'll be something to actually see, go back and look at how well does the ones reported clinically track with the ones that we do for research. Because the research ones are done offline afterwards, but it's done by somebody who's done hundreds of this.
So the data we presented are based on retrospective analysis. You didn't reanalyze the strain and the eccentric index for the study.
Sorry.
You just took the measurements which were provided in the report. This was a retrospective study.
No. So that's part of. So when I joined the practice. So part of what we did to make our research better was that every image analysis is done offline, just to maintain that rigor and reproducibility. So everything is done. So a research sonographer goes in for every patient that is in the database and does measurements in the same way. So for research, everything is done is different from the clinical measurement. But we've not really done a study to see how well both of them track. But it's just better to do the research thing for research.
That's my last question. Ebstein patients are a very heterogeneous population, even those who are referred for surgery. Every patient is different. And some patients undergo a bidirectional Glenn anastomosis. Have you had a look on the impact of the Glenn anastomosis on your output parameters like the strain and strain analysis?
No, and the reason for that is that we have very few patients that had the Glenn. So it's a single surgeon. He's not in favor of using that just because it was done initially in people that had really, really bad RVs. And so it works in kids. In adults, it just doesn't work so well. One is that the low output that they have, and two is that those patients have RVs that are so bad that you end up replacing a tricuspid valve. So even if you use a bioprosthetic valve, they tend to clog their valves. So if we can achieve a normal repair, then the patient should go for transplant evaluation.
So Alexander, I think we're near 9 o'clock, but I have a last question. I strongly believe, and I think you have proven this today, which is I'm really glad that Ebstein is not a right heart problem. I think it's a right and left heart problem. I strongly believe that, and I believe that for many years. You open the box of heart failure medication in patients that have an occult LV dysfunction, which as an idea is a good idea. But my question to you is, have you had any experience, or did you have any experience in the Mayo with some patients that I'm sure that even if the number is small, where you have tried heart failure medication and had made a difference or have changed anything?
I wish I could tell you that we've been very good at using these medications in our patients. The thing is that especially the people with the occult LV dysfunction that have normal EF, most of them are not on beta blockers and ACE inhibitors. So we are under treating them. So part of how this has changed our practice is being able to identify these people with LV dysfunction and hopefully treat them, not just giving them lisinopril 5 milligrams. You give them the maximum tolerated dose, because that's what the clinical trials show, that the higher the dose, the better the response. And it should work since it's the LV, but we've not really looked at that.
So I have my last question, and it's a complex question, but so I understand the eccentricity index makes a lot of sense to me. Why change? So it's an index that in the pulmonary hypertension world, actually at the beginning of the pulmonary hypertension, when the drugs start to develop, was an index that we used for prognosis, and it's still been validated for prognosis in pulmonary arterial hypertension. And I understand that it's a mechanical thing, right? So you have no space, the ventricle has to expand, and that's it, just shifting the septum. So I understand why that changed, but what do you think is the reason why the global strain, the strain is measuring what happened in your muscle on the left, in the left ventricle. So what do you think why do you think that the strain change in the left ventricle over time? It's just a feeling problem, or is a intrinsic problem of the ventricle?
No, I don't know about the change in the strain in the LV.
Yeah,
you're talking about. Yeah. So I don't know exactly why that's the case, but it looks to me that I mean what I can just deduce from the data is that for whatever reason that there is LV dysfunction, that it is progressive in these patients. So I'm not really sure why there's a deterioration in it, since they don't have ischemic cardiomyopathy, but something is wrong with the LV myocardium, but it's progressive.
Mm-hmm. Yeah, so that is, I think, it's an interesting topic to understand how the medication can help this patient. So well, it's 9 o'clock, so really great lecture. Really, thank you again for joining us today, and for giving us all of these new insights in the Ebstein anomaly, and giving us this great talk. So, and to you all that you have joined us. So see you here next week, and good morning, good afternoon, or good night, wherever you are in the world. Thank you, Alex. See you around.
All right, no problem. Thank you so much for having me.
Bye-bye.